Merci, surtout d'avoir souligné cette question de financement de la santé. Et je voudrais, au nom de l'Union africaine, remercier les pays qui ont contribué pour faire face à l'Ebola. Nous allons poursuivre, et cela, mesdames et messieurs, avec le représentant de l'ODANEPAD, Madame Nardos Bekele Thomas, sur l'équité en matière de santé et déterminants sociaux de la santé.
Thank you very much. Excellencies, presidents, and heads of states present here, our chairperson of the African Union Commission, all honorable ministers in attendance, colleagues from the African Union organs, international organizations, my former UN colleagues that are here, I want to salute you, and also our partners, including the one who is really an African for Africa and fighting all the time for us, you know, the Susan Buffer Foundation. So, you know, I would like to recognize you, Professor Sanait. Distinguished leaders, ladies and gentlemen, thank you for the opportunity to address health equity and the social determinants of health. That is the topic I was given. An agenda which is central to Africa's inclusive transformation and to the African Union Development Agency's mandate to turn continental commitments into practical delivery. Health equity is not achieved by the health sector alone. It is achieved by the conditions in which people are born, in which people grow, learn, work, live, and age, and by the public choices that determine whether those conditions protect life or reproduce vulnerability. The data are unequivocal. Global evidence shows that social determinants can shorten healthy life expectancy by decades. The difference in life expectancy between countries is as wide as 33 years. Children born in poorer countries are 13 times more likely to die before the age of 5 than children in wealthier countries. And eliminating wealth-related inequality within low and middle-income countries could save an estimated 1.8 million children every year. These figures tell us that health inequity is not accidental. It is produced where access to quality education is limited, literacy is low, nutrition is inadequate, housing is unsafe, water and sanitation are unreliable, livelihood are insecure, transport is unavailable, and essential services are too distant or too costly. In short, Your Excellencies, health challenges cannot be dealt by ministries of health alone. We need multi-sectoral coordinated approaches at the national, regional, and continental levels. A mother, ladies and gentlemen, may arrive at a facility with complications, but the chain of risk often began much earlier with poor nutrition, interrupted schooling, insecure income, inadequate transport, weak primary health care, and delayed access to quality-assured medicines. The strategic implications, ladies and gentlemen, is clear. Disease-specific progress cannot be sustained on systems that continue to reproduce vulnerability. Social determinants must therefore move from the margins of health policy to the center of how we plan, how we finance, and how we deliver development. For Africa, health equity must become a disciplined model of government. It must guide how we allocate budgets, design infrastructure, strengthen primary health care, expand social protection, build resilient supply chains, and use data identify who is being left behind. This is, ladies and gentlemen, precisely where the African Union Development Agency's work is relevant. We operate at the intersection of health, financing, infrastructure, industrialization, agriculture, education, digital transformation, and regional integration. Our task is to help member states translate equity from a principle into implementation. First, we are advancing sustainable and equitable health financing through the Africa Leadership Meeting on Investing in Health, which is led by President Kagame, and the Program for Investment and Financing in Africa's Health Sector. The Africa Union Development Agency supports member states to strengthen health financing governance, mobilize domestic resources, unlock blended capital, and develop investment-ready health programs that respond to national priorities. The focus is not only to raise more resources, but to ensure that resources are allocated to the people, to places and services where exclusion is greatest. Primary health care, community systems, women and children, underserved districts, and the medicines and technologies that save lives. Second, we are strengthening primary health care as the front line of equity. Strong primary health care identifies risk earlier, prevents diseases, links households to nutrition and social protection, and brings quality services closer to communities before illness becomes catastrophic. Before we get all these pandemic things that my dear brother was talking about, the Ebola and the HIV/AIDS and all the pandemics and epidemics. Third, equity depends on access to essential medicines and health technologies. For too many Africans, the distance between a diagnosis and treatment is measured not only in kilometers, but in price, in availability, in regulation, in procurement, and supply chain delivery. African Union Development Agency's 24 priority medicines and the securing access to life-saving medical products, which we call SCALE, initiatives, addresses this full value chain by aligning regulatory strengthening, local production, pool demand, financing, and last-mile delivery around the products with the greatest potential to close access gaps. Through the Africa Forum for the Federations of Medical Products Manufacturers, we are coordinating private sector efforts towards local production and access and preparing the African manufacturers for competitiveness. Fourth, through the African Demographic Dividend and Sexual and Reproductive Health Program, we are addressing inequity where it is mostly deeply reproduced in the lives of women, adolescents, and young people, courtesy of my dear sister, Professor Sanait. The ADRI is our NEPA's 5-year program supporting member states and regional economic communities to strengthen sexual and reproductive health, primary health care, and universal health coverage, while investing in young people as the foundation of Africa's demographic dividend. It moves SRH beyond a narrow service agenda by connecting it to education, youth employment, social protection, gender equality, financing, and accountable institutions so that girls stay in school, young people access quality care, and national commitments translate into financed implementation. Finally, equity requires better data. We must measure who is served, who pays, who is protected from hardship, where medicines are available, which districts are falling behind, and where investments are reducing gaps by income, gender, geography, age, and disability. Excellencies, in addition to these health initiatives, our Skills Initiative for Africa and Education Program are helping member states bridge the gaps in education skills development and youth youth employability, key social determinants of health and well-being. Furthermore, through our agriculture, food systems, and nutrition programs, we are supporting efforts to improve food availability, strengthen access to nutritious diets, and enhance the nutritional status of families, with particular emphasis on women and children. Excellencies, addressing Africa's health challenges requires a comprehensive, multi-sectoral approach. Health outcomes are shaped not only by health, just a minute, by healthcare systems, but also by education, employment, food security, and all the other broader socioeconomic development. Real change in health inequity will require us, finally, to govern differently. It will require health finance, education, agriculture, infrastructure, trade, and social protection to organize around the same people and places using shared data, shared accountability, and shared investment plans. Health equity must be visible in the way we allocate budgets, build infrastructure, procure medicine, design digital systems, protect households from financial hardship, and deliver services to the last mile. Because the Africa we want will only be realized when the circumstances into which an Africa is born no longer determine the quality, dignity, and full potential of their life. I thank you and sorry for taking that.
Merci. Merci, Excellences, Mesdames, Messieurs. Nous allons finir cette série de présentations avec celle de la directrice générale de l'Agence africaine des médicaments, Dr. Delès Mimi Darko. La parole est à vous.
I'll be very short.
3 minutes.
Yes. Your Excellency, President John Dramani Mahama, President of the Republic of Ghana, Excellencies, all protocol observed. It is a profound honor to address the extraordinary session today as the inaugural Director General of the Africa Medicines Agency. 25 years ago, Africa united to confront HIV/AIDS. What we proved was that when Africa acts together, Africa succeeds. Today, the work before us is no longer simply a fight for a disease. It's to build institutions that will protect every generation of Africans from disease. We know that health security protects us from crisis. It is health sovereignty that ensures that we are never again vulnerable to those crises. But both require one foundation, and that foundation is trusted regulatory systems. AMA builds on the strong foundations laid by the Africa Medicines Regulatory Harmonization Initiative under the AUDA NEPAD and the WHO AVREF, bringing Africa's regulatory excellence together under one permanent continental institution. AMA works hand in hand with national regulatory authorities and communities. AMA does not replace them. They are sovereign. AMA strengthens their capacity to ensure that medicines, vaccines, diagnostics, and innovations can be trusted from clinical trials and manufacturing to supply chains and patient safety. Through harmonized regulatory pathways, we are working towards one application, one scientific review, multiple markets. Through the network of African and the African Safety Monitoring System, Africa is strengthening quality assurance and for the first time generating its own continental safety data. Through AMA's newly established Regulatory Innovation and Manufacturing Readiness Hub, AMA is creating Africa's front door for manufacturers and innovators, reducing regulatory uncertainty and accelerating access to quality-assured African health products. During this Ebola outbreak, we supported the affected countries to review clinical trial protocols and walked an African manufacturer from Egypt through the regulatory process to manufacture an Ebola vaccine. This was done with African regulators on the continent, showing that Africa does not lack scientific knowledge. We just need to work together. Through the AfriVigilance, it is an AI-enabled digital continental safety and quality platform. AMA will ensure that when a safety signal emerges anywhere in Africa, every member state will know about it and can act in a timely manner to protect its citizens. For the first time, we will have African safety data generated by Africa, in Africa, and for Africa. AMA believes that Africa must not join the innovation journey after all the critical decisions have been made. Our populations, our genetics, our disease burden must help to shape medicines of the future. AMA makes this possible by building a trusted regulatory environment that will attract innovation and will keep the innovation in Africa, because innovation should never widen inequity, it should reduce it. AMA will work closely with the Africa CDC to strengthen Africa's health security and with the Africa Continental Free Trade Area to ensure that quality-assured medicines move efficiently along the continent. Your Excellencies, my appeal today is simple. I urge every member state that has not yet ratified the AMA Treaty to do so. 33 member states have done that so far. We need the remaining countries to do so that the impact of AMA can be scaled. Where a ratification has taken place, please let it be matched by sustainable financial support. An institution that is ratified but not resourced cannot deliver the health sovereignty that this Assembly seeks. Together, let us make AMA truly Africa's agency to deliver quality medical products for the patients we serve. Excellencies, I thank you. God bless you.
Merci beaucoup, Madame. Maintenant, nous allons marquer une petite pause. Je voudrais saisir cette occasion pour remercier nos invités pour leur attachement à nos travaux et je donnerai la parole au maître de ces activités.
Thank you, Your Excellency. Excellencies, ladies and gentlemen, allow us now to proceed with the family photo. For this purpose, I kindly request all other delegates to remain in their respective seats, for instance, to ensure the orderly organization of the photo. I respectfully invite the following to proceed to the photo venue outside. The Honorable Heads of Delegation of the Member States, His Excellency the Chairperson of the African Union Commission, Her Excellency the AU Commissioner for Health, Humanitarian Affairs and Social Development, His Excellency the Deputy Chief of Staff to the Chairperson of the Commission, the Honorable Heads of Organs and Specialized Agencies of the African Union, the Honorable Heads of Regional Economic Communities, the Honorable Heads of United Nations Specialized Institutions, international organizations, and African financial institutions, the Secretary to the Commission, and the Legal Counsel. After the photo, we will have a coffee break. Please, Excellency, can you tell us at what time we have to come back here for the closed session? On va revenir à quelle heure? Ici. La pause, on va avoir la pause café.
Une demi-heure.
Une vingtaine de minutes?
Une demi-heure.
Une demi-heure. Je vous remercie. Donc, on sera ici à 1 heure à peu près. 1 heure. Voilà. Je vous remercie. Protocol, please. Est-ce que vous pouvez nous assister pour aller vers la photo family, assister les head of delegation and the high table? Thank you. Protocol team, please.
The heads of delegations.